Good morning from the Hawaiian Eye Conference in the Big Island of Hawaii. We're pleased to be here today with Dr. Marjan Farid, one of our ASCRS Cornea Clinical Committee members. Thanks a lot, Marjan, for being with us today.
Absolutely. Thanks so much for having me.
Marjan, you had a great session at this conference about dislocated IOLs, and this is a particularly challenging problem because oftentimes no two dislocations are alike. I'm wondering if you can start us off by explaining to us what may predispose people to a dislocated IOL, what kinds of things can happen that cause this event, and then we can talk a little bit about how to manage it also.
Absolutely. So one of the most common causes of a late dislocation of an intraocular lens is pseudoexfoliation. So patients have had non-complicated cataract surgery a few years back, and over time those zonular dehiscence and weakness occurs and the lens dislocates or sunsets often while it's in the capsule. You know, another common cause is trauma. I've had many patients who have had minor trauma. Maybe they had previous zonular weakness, but then the lens dislocates. So multiple causes.
Marjan, I'm glad you brought up trauma, in fact, because I get concerned phone calls or concerned questions from patients all the time. You know, I accidentally, touched my eyelid, or I accidentally rubbed my eye for a second. Right. Is my lens going to move or something? What kind of trauma are we talking about here? Are we talking about that kind of minor trauma, or is this more like motor vehicle collision type trauma?
Exactly. So yeah, minor trauma, I get that call all the time from patients after cataract surgery. No, you're not going to dislocate your intraocular lens with that minor trauma. These traumas are usually more robust, although if the patient has, again, a predisposition for loose zonules, pseudoexfoliation. I've had patients who've had severe coughs, for example, who dislocate their lenses. So, you know, it's got to be pretty forceful trauma, or if they're predisposed, things like aggressive coughing or jarring of the head can also cause dislocation,
That makes good sense. Let's shift gears for a moment, Marjan, and speak about management. I suppose that depending on the mechanism and the extent of dislocation, your management may differ from case to case, but it seems that there are some techniques in which you can preserve the existing IOL bag complex and other techniques where you need to explant and then reinsert a secondary IOL. Can you talk a little bit about those scenarios?
Absolutely. So my approach is usually I try to keep the lens that was in there as long as the power was right. And minimize the surgical trauma to the eye. An exchange is always possible. Obviously, if there's vitreous coming around and there's such a severe dislocation that we need to involve the retina team, often those lenses need to come out. But lenses that are sunsetted or partially dislocated, the first thing I look at is what type of lens is it? Is it an one-piece lens that's in the capsule? Is it encapsulated? Can I just reposition the entire lens capsule to the sclera and use a suture fixation like a lasso fixation to really solidify and position that lens back to the wall of the eye? Or is it a three-piece lens? If it's a three-piece lens, then it's a little more versatile. I have a little bit more option. I may want to suture it to the iris, although I'd need good iris anatomy for that. We may also be able to externalize those haptics via Yamani technique and be able to stabilize the lens that way. So it really depends on the type of the lens, where it is, how easy it is to access, and so on.
Those are some great points. And Marjan, I want to back up for a moment where you spoke about a one-piece IOL in the capsular bag complex that has sunset or dislocated. What about if that IOL bag complex has an existing capsular tension ring? Does that help you or hurt you, and in what way?
Absolutely, yeah. So always put in a capsular tension ring in these pseudoexfoliations, because if there is a late dislocation, they can actually help. So it'll give us a little bit more of a surface area to hook, do an over-under technique with either a Gore-Tex suture or a ninoproline suture to be able to hook that capsular tension ring and then refixate it to the sclera. So it helps.
Well, Marjan, these have been some great points for us, some great take-home points about dislocation of IOLs late after cataract surgery. Thank you so much for sharing your expertise this morning.
Absolutely. Thanks for having me.